Hello to everyone who's watching this video. So today I'd like to discuss with you abdominal X-ray and its interpretation. Before we start, I'll just want to tell a couple words. So I'm Dennis Bunchak, I'm MD, graduated from Ivano-Frankivsk National Medical University back in 2017, and I was always passionate about teaching, so today I will do my best to explain and to give you some insights about abdominal X-ray. I want to let you know that it's not an exhaustive list of abdominal X-ray, and there might be something that is missing, but I'm hoping again that I will give you insights to understand it better and to know and what you see on the abdominal X-ray. So the structure of today's lecture is next one. We'll start with a small introduction, then there is an approach to the abdominal X-ray, the steps like confirm details, assess image type and quality, and then assessing the X-ray with these mnemonics ABBC. So there might be people who use different mnemonics, and in my opinion there is no such a thing that wrong mnemonics are right, but it's just about the structure. If you structure the approach to the X-ray, you will it's less possible that you will overlook something and you will hit all points and all details of the X-ray. So buckle up and let's begin. A small intro. Abdominal X-ray is very useful, and it doesn't have as high exposure of radiation, so here it is just 0.07 millisievert, while chest X-ray is 0.02 millisievert, and then CT, for example, abdominal CT is from 5 to 10 millisievert. We use abdominal X-ray to investigate the organs that are in the abdominal cavities, like stomach, liver, intestine, spleen. So when medical workers, doctors, physicians trying to assess kidneys, uterus and bladder, it's known as a KUB X-ray. Yes, and because this is a fast and easy investigation, it is often used in the emergency room to help to figure out what is happening with the patient. So where to start? I would advise to begin X-ray from confirming the patient details. It's good, and actually it's right to know that you are assessing the right patient. So check the patient's name, date of birth. Also check when the film was taken. Once I read that the best X-ray is one that was done before, so if you have a previous X-ray, it would be a great asset for you because you can compare it to this one that you want to do. So after you confirm the details of the X-ray, abdominal X-ray film, you then assess image type and quality. So there are different projections of abdominal X-ray. It can be supine positioning, anterior-posterior, decubitus positioning, and upright positioning. So there are some benefits and drawbacks in each of this positioning, as it said here. So decubitus is good to detect free intraperitoneal gas, but it's important to let the patient lie for a bit, that the gas rise up on the side. Then erect or upright positioning is also good for air fluid levels and free intraperitoneal gas, while the supine positioning doesn't give that resolution of air fluid levels in the intestine. After assessing the projection, it's important to check that the X-ray covers the whole abdomen, starting from diaphragm and finishing with pubic symphysis. It's good to know that the exposure is adequate. You can see the bodies of spine vertebra, lumbar and thoracic, and also that you can see the large and the small bowel. Then you need to notice any artifacts, and also it's important to check where is right and where is left, where is right and left side. After doing those things that we mentioned, it's time to begin assessing the abdominal X-ray. So I do like this phrase here. You see what you look for and recognize what you know. And I think that's the great motto for today's lecture presentation, because if we know what we're looking for and what this will help us to recognize it. So mnemonic ABBC include the next: A as air in the abdomen, B for bowel and other organs, they're all here, another B for bones, and C for calcification and artefact. So let's start with air in the abdomen. I structured the slides in that way that you don't see the answer for the X-ray for a bit, so if you need to think more, just pause the video. Otherwise I will wait for a couple seconds and then reveal the answer. So here is the hint with the arrow, but still you look at the X-ray. You done all the previous things, you check the name, the date when the film was done, you check the exposure and does the X-ray include all important parts, and then you start to assess it. So as it said, start from A, standing for air in the abdomen. So this one, X-ray, regarding the air, shows the arc-shaped gas densities. It's over here and it's crossing the diaphragm. Beside that, you can see the air fluid level here and the distended intestines. There is the air under diaphragm. So what happened, often it is hard to assess and to see air on the diaphragm, and if there is a strong suspicion for it, I would usually order the erect chest X-ray, because it has higher sensitivity and specificity, and on this erect anterior-posterior chest X-ray, you can see that there is the air here under diaphragm, and it crosses the central tendon of the diaphragm. And again, there is distended loops, bowel loops over here. Another sign that can be used to recognize the gas or air in the abdomen is this one. Again, here is the hint with arrows. So it calls Rigler's or double wall sign. Normally you don't see the two sides of the wall because the gas is only present inside of the lumen of the bowel, but if you have the gas outside, it will result that both sides of the bowel, inside and outside, will be visible. Again, it calls Rigler's or double wall sign. You can see that here is a distension of bowel loops, both small and large bowel, and the air, the sign, Rigler's sign. A was for air in the abdomen. B, the first B stands for bowel and other organs. You know, when you start, and it might be a bit difficult to recognize where is the large and the small bowel, but to help you, I have here the notes that helps to recognize them. So the small bowel usually lies in the central part, while the large bowel is on periphery. Then there is mucosal folds in the small bowel. Unfortunately, it's not that visible in this case, but they are called valvule connivitis, and their specificity is that they cross through the full whites of the bowel. On the other hand, the mucosal projection in the large bowel, which are called haustra, they do not cross the whole lumen of the large bowel. And also they thicker than the valval concavities. So another specific detail about the bowel, it's to consider is there a distension or not, and the different literature gives kind of different approach to this, but I do like this rule 369. It's easy to remember. So the normal width of the small bowel is 3 centimeters for a colon, except the cecum it's 6 centimeters, and the cecum is considered normal even if it reach up to 9 centimeters. Over here is the normal abdominal X-ray. You can see the large bowel, ascending transverse colon and descending and sigmoid, and you can see the haustra. They do not cross the whole lumen of the large bowel. So here is another case, abdominal X-ray, and here we can see those mucosal projection. Again, to differentiate, first you think about location. This bowel is located centrally, so that's a hint it might be a small bowel, and again you see that this mucosal projection, they cross the whole lumen of the bowel. And the answer? So this radiograph shows dilated small bowel loops. You can see them, and this is a sign of small bowel obstruction. Again, this is the same patient from the previous video, not the video, but from the previous slide, but this is the erect abdominal X-ray. The previous one was supine. The arrows give some hints to the case. So you see multiple air fluid level, which in keeping with a small bowel of obstruction. And again, the lumen of the small bowel is greater than 3 centimeters, so it is considered distended. Another case. So again, you don't forget to start with confirmation of details and the name, and when the film was done, you consider the quality of the film. Does it cover everything that you need to know? You start with the air in the abdomen, then you go to the bowel, and so we can see the lumen of the bowel is distended, and the mucosal projections doesn't cross the whole lumen, so it is the large bowel. Here is the replaced hip joint, and this is large bowel obstruction. The bowel lumen is filled with gas and distended up to the distending colon. Small bowel is collapsed here, we cannot see it, and no free gas inside of the abdominal cavity. Another case, so I'd say it's kind of classic. Duodenal atresia. The sign that you see here, double bubble sign, one for stomach, another one for the duodenum, and here you can see the projection of the nasogastric tube. Another case, assessing the bowel. So, necrotizing enterocolitis. You can see that there is multiply density distended loops of the large bowel here, small bowel here, and there is the modeling over here, in keeping with the gas, intramural gas, or pneumatosis intestinalis. Another case. Sacral volvulus. So this is a plain radiograph that displayed the sacral dilation. It is distended, and there are the loops of the small bowel. They are also dilated. Another I'd say classic case. It does look like a coffee bean to me. Sigmoid volvulus. It's a bit different than the sacral volvulus because the volvulus in the previous case happened on the cecum, and here it's a sigma. You can see the markedly dilated loop of the column that represent the coffee sign or coffee bean shape. Its apex is pointing to the right upper quadrant, and we can see the lucency at the right edge of the dilated bowel over here, representing the compressing ascending colon. So again, starting with everything that we heard about before, and slowly going from A to B bowel, and we see over here inflammatory bowel disease, and specifically here toxic megacolon. There are different causes of the toxic megacolon. Beside the inflammatory bowel disease, it can be infections such as Clostridium difficile, and the film presents the colonic dilation. It is dilated. It is more than 6 centimeters. Loss of normal haustration, and another thing is thumb printing, like someone pressed their thumb here, which represent the mucosal edema within the colon. And this is the case in the child with inflammatory bowel disease. This one is X-ray with barium, abdominal X-ray, and again inflammatory bowel disease, chronic ulcerative colitis. The phenomenon that is seen here is called lead pipe sign or featureless and featureless colon. No haustration here. It looks like a lead pipe. We're skipping in chronic ulcerative colitis. So again, assessing everything slowly but steady, starting with checking the date, the patient information, the exposure of organs that we are interested in, then looking for air in the abdomen, and then assessing the bowel. And here you can see that the descending colon is distended here, and over here is an abrupt transition point, which in keeping of colorectal cancer. So now for the other organs that can be seen on the abdominal chest X-ray. So here is the liver, spleen, one kidney, another kidney, the ascending colon, transverse colon. That's the other organ that can be assessed. Beside them, there is another slide. Again, a liver, spleen. Here's the rib, 11th rib on the left side. Kidney. This one is a projection of the urethra that goes down to the bladder. Over here on both sides is a psoas muscle. This is sacroiliac joints, both sides. So here's another case regarding the other organs. You assess the name of the patient, the date of the X-ray film was done, assessing the exposure, assess the air in the abdomen, then the bowel, which is good here, and then you starting to assess other organs in the abdominal cavity, and it is quite striking here. This is enlarged liver, but in this case this is actually the variant of normal situation because of the kidney, right kidney that is not displaced. It means that liver enlargement is from a radial lobe, a normal variant. When the entire liver is enlarged, that would displace the whole organs, the kidney also. Another case, assessing everything, coming up to the other organs after checking all other. And you can see here, this is enlarged spleen, splenomegaly. That was B. A for air in the abdomen, B for bowel and other organs, and another B for bones. There are quite a few bones that can be seen on an abdominal X-ray. Some of them ribs, thoracic and lumbar vertebrae, sacrum, coccyx, pelvis, and proximal femurs. The last one, C, for calcification and artefact. There might be a different calcification that can be seen on abdominal X-ray, gallstone, calcified gallstones in the right upper quadrant, renal calculi, pancreatic calcification, vascular calcification, costochondral cartilage calcification, contrast, surgical clips, metallic umbilical jewelry, foreign bodies. This is another case. From the first moment, it actually, at least it was quite hard for me to spot it, and you need to pay attention. Kidney stone. The round radio opacity lies superior to the L4 body, in keeping with the renal stone. Another calcification can be seen here. Gallstones in a sac-like morphology in the right upper quadrant. It is, I'd say, striking normality over here. Chronic pancreatitis, diffuse and homogeneous calcification in a hypogastrium. Another thing that can be seen in on the abdominal X-ray is this. Foreign body. In this situation, it's a paperclip. So while children, they do more often ingest the foreign body, there are adults that also do it. So don't be surprised if you see here like 2-3 forks, screws. That can happen. So here is the references for materials that I used when I prepared this presentation. I hope this video will be useful for you. Don't get discouraged and frustrated when you're trying to assess the abdominal X-ray. Just stay calm, have your structure that is good for you. You can use this one that I presented here, ABBC, or you can use another one. Just keep with that structure, and the more abdominal X-ray you assess, the better you'll become in it. Just don't worry. I hope you guys enjoyed this video. Have a great day or the evening, depends whenever you watch this video, and stay safe. Thank you so much.